good afternoon. Is my screen shared?
I can hear you and I can see your screen.
Okay, perfect. So I'm Shelby Schroeder. I'm a physical therapist. I work at Baptist Health Floyd in the acute care department. So I work in the hospital, but I've had some experience working in outpatient and rehabs as well. Graduated from Bellarmine and completed a neuro residency through Bellarmine and Norton. So I have a special interest in treating individuals with neurological disorders, but have taken kind of a niche area of practice in treating people that are dizzy or have vestibular disorders. I am adjunct faculty at Bellarmine in the Doctor of Physical Therapy program in the Adult Neurological Disorders course. So love educating about the dizzy population, advocating and just kind of getting this information out there so to help these people get better. So, okay, so no disclosures to report. This is what we're going to go over. I know this is the last one of the day. I'm sure today has been great, but let's talk about some dizzy people. We're going to talk about normal function of the vestibular system or the inner ear. I'm talking about the inner ear when I say vestibular, and highlight some considerations for older adults, talk about different types of causes of dizziness and how a physical therapist would help treat and prevent. And then I have a case review if I have time at the end. So older adults and falls. Minimize myself. There we go. So once a year, 23% of older adults fall. So definitely a big issue there. And some things that increase the falls risk are dizziness, depression, and comorbidities and polypharmacy. Those are some big things to look out for with these individuals. And some more details here. So these are some things that also might contribute to falls risk. So older adults sometimes have postural deformities like forward head or rounded shoulders that can pitch their center of gravity more forward. Looking down at the floor, all those things can increase their falls risk. Cognitive function, if they have any difficulty with their cardiovascular system, if they have arthritic pain or changes in their vision or hearing. We talked about medications. If they're fearful of falling, it actually increases their falls risk too. If they have diabetes, it might lead to loss of sensation in their feet, which will impact their balance. And high blood pressure can cause dizziness. And then urinary or bowel incontinence, just trying to rush to the bathroom on top of all those other things, can definitely lead to falls.
Hey, Shelby, I don't think we're seeing your slides progress.
Okay. It said that my screen sharing is paused. I'm pressing the play button, but it's not saying that it's resuming the share.
You may have to take it out of the presenter mode and just show it with the little things on the side and everything. Take it out of presenter mode, and I think you can move it forward then. It'll be a smaller screen, but that sometimes works on Zoom.
Okay.
Thanks, Floyd. I was looking hard to see if I could find a button to correct it, but I couldn't.
It says I'm screen sharing now. So can you see my screen there?
You're on special considerations with older adults is the slide is on. Okay.
Yes. Okay. And then can you see the next slide? Simple screening questions.
Yes, ma'am.
Okay, perfect. So is this what you said I'll have to present it from, not in presenter mode, but from here?
If you try presenter mode again, you could try it, but I've seen it where this is how you have to
Or it
do it.
doesn't work. Oh,
Yeah.
okay. All right.
You get tricky.
Okay, so here are some simple screening questions to help assess falls risk in older adults. So are they incontinent, depressed? Do they have any loss of sensation in their feet? Dizziness, taking 4 or more medications? Do they have trouble getting up from the floor? Are they fearful of falling? And if the answer to any of these is yes, then their falls risk is increased. So just to visualize the vestibular system, since that's specifically what we're talking about here, here are some pictures. So we've got you can kind of see how small the inner ear is in comparison to the ear itself. So we've got the outer ear, and then going into the cochlea and the tiny little semicircular canals. And then the right picture is the cochlea and the nerves that supply the inner ear. And then the semicircular canals are on the right side. And then where it says utricle, that's where the otoconia, or the tiny little crystals that cause BPPV or vertigo, are supposed to be. And then they get dislodged and they go into these semicircular canals, and they're free floating in there. And the whole point of physical therapy treatment for BPPV is to do a series of head positions to get those crystals back in the utricle where they belong and where they help the brain sense head position, instead of the semicircular canals where they tell the brain that the room is spinning and make us really off balance and dizzy. So that's kind of the process for BPPV in particular. So here are some common causes of dizziness in older adults. So the bolded ones are the 3 most common. So relating to the vestibular system, we have benign paroxysmal positional vertigo, which is BPPV, which is what I just described. And then there's some others listed there that are less common. And then there are some issues related to the brain, the central nervous system that can cause dizziness, and the heart, and the vascular system. And then, so postural hypotension is the second most common cause of dizziness in older adults, and then medications. So there are lots of medications out there that can cause dizziness, and some of them are listed here. Also, changes in vision and musculoskeletal system can cause dizziness as well. So this is a graph of vestibular disorders relative to age. So we've got 3PD, which is a disorder that leads to persistent dizziness. Starts with an acute attack of dizziness and then becomes chronic. And that is more common. So the dark blue is older adults and the light blue is younger adults. So that's more common in younger adults. And then we've got migraine, which is more common in younger adults. And then we've got disorder of the nerve to the inner ear, unilateral vestibular hypofunction, which starts to be more common in older adults. Meniere's disease, more common in older adults. BPPV, much more common in older adults, along with vascular vertigo, which is even more common in older adults. So related to typically stroke, the vascular vertigo. And here is another illustration of causes of dizziness in the ED. So this is not specific to older adults, but this is what will bring people into the emergency department. I work in the emergency department at Baptist Health Floyd. We just this week launched a program where we have a physical therapist full-time staffed in the ED. And so this is kind of where I'm hanging out right now and see dizzy patients pretty regularly down there. So the most common diagnosis that somebody would complain of dizziness for coming into the ED is related to the vestibular system BPPV. And then we have cardiovascular events, stroke, acute unilateral vestibulopathy, which is the disorder to the nerve that supplies the inner ear that I was talking about. And then just some other less common causes, but there's multiple vestibular causes in here. So 48% of dizziness related to vestibular disorders is related to vestibular disorders in older adults. So we said, 25% that come into the ED have BPPV, but even almost half of the reasons that older adults are dizzy is coming from the inner ear. So we've definitely got to pay attention to the inner ear when older adults are dizzy. So if we identify the cause early and treat it early, we can improve outcomes and we can try to reduce the risk of falls and of this becoming a chronic issue. So some additional statistics about the ED. So of all of the people that come into the emergency department, about 4% of those people are dizzy. There's about 4 million ED visits per year due to dizziness. And it's very costly to manage these patients because they get all these tests to make sure that they don't have a heart problem, they don't have a brain problem. And then it ends up, no, they don't. They just have, an inner ear problem and they need physical therapy. So older adults with BPPV are more likely to have falls, depression, caregiver burden, and unnecessary medical treatments. So all the reason to get them to see a provider quickly that can help them address this. So BPPV, this is kind of spelled out what this abbreviation is for: benign paroxysmal positional vertigo. People that have this might kind of feel like this ride right here, like they're going round and round. Some definitions related to vertigo. So it's the sensation of motion of the self or surroundings, but they're not actually moving. So the brain is playing tricks on the person to make them think they're spinning or the room is spinning. And positional vertigo, which is what happens with BPPV, is it only happens in a certain head position. BPPV is a disorder of the inner ear that happens repeated episodes. Every time you get your head in a certain position, you get the same sensation. A lot of times it's when we roll over in bed. We often hear vertigo as a diagnosis, but it doesn't specifically diagnose to say somebody has vertigo, because there are multiple issues that can cause a sensation of room spinning dizziness. So we like to dig a little bit deeper and figure out, what is causing your vertigo. There are other types of dizziness, and these help us differentially diagnose what is causing the patient to feel this way. So if they're lightheaded, or if they have disequilibrium, a feeling of off balance, or oscillopsia, they feel like their vision is bouncing as they're moving. All those things can have different causes. So here are the diagnoses that are correlated with these different sensations. So we've got BPPV, nerve issues related to vertigo. Lightheadedness can be hypotension, hypoglycemia, anxiety, panic, and then feeling off balance is a whole list of things, some related to the inner ear, some related to the brain. And the bouncing of vision is generally related to a hypofunction of both ears. So your patient with BPPV may say they're having discrete periods of vertigo. So it lasts less than a minute. They might have it while they're in bed, while they're leaning back and washing their hair, while they're leaning way forward and gardening, tilting their head to look upward, bending over to pick up an object. All those things would stimulate the head position needed to trigger that dizziness. And they might not always say the room is spinning. Dizziness could could be lightheaded, nausea, or feeling off balance in these cases. So sometimes we miss the diagnosis of BPPV because they're saying things that aren't room spinning dizziness. They're saying, I'm feeling queasy, I'm feeling a sense of tilt, I have blurred vision, my balance is off, I'm having trouble walking, but they might not feel the sensation of spinning. And this can be related to vestibular agnosia. So vestibular agnosia is an impaired dizziness sensation, a loss of the vestibular perception of self-motion. Now, it means that when they get, the crystals are out of place, but they don't feel dizzy, but they get other side effects this that might be falls. So older adults are more likely to have this vestibular agnosia, and it leads to a reduction in the clinician recognition of BPPV. It's more likely to get missed if they're not saying they have room spinning dizziness. So the reported symptoms of BPPV alone do not necessarily lead to the proper diagnosis. So meaning that we need to screen people for BPPV if they're older adults and they're falling and they're at risk for this disorder. So this was a study that looked at vestibular agnosia. So in the UK, there were people over the age of 65, 40 people referred to a falls clinic, and they were looked at to see how many times they were falling per year. 6 months later, they looked at how many falls they were having per year. So they were tested for BPPV. 12 of the 40 people with nystagmus in the Dix Hall Pike did not report vertigo. So they didn't feel the typical room spinning dizziness, even though, so nystagmus, I'll have a video of this shortly, but it's like a movement of the eyes, either it's going like this or like this, and it indicates that it's the positive diagnosis for BPPV. So they had the diagnosis for BPPV, but they didn't feel dizzy. But the total number of falls reduced significantly after they were treated for the BPPV, and their falls had a 64% decrease after they were treated. So it was effective. They were falling significantly less after being treated. So older adults may have postural abnormalities for up to 3 months after the repositioning. So in a lot of younger people, if you fix this, they're 100% better, just like that. You treat them for it, 1, 2, 3 treatments, they're better, and they're out the door. They never have issues after that. Older adults, the symptoms can linger longer. So we need to assess their balance after the BPPV has resolved. Now, vestibular suppressant medication should be limited to only during the really dizzy acute phase with older adults, because it might cause side effects for older adults and drug interactions. Sometimes you'll see people on meclizine for long term after they've had a dizzy episode, and they take it every day for long term. Nobody ever takes them off of it, but it can actually lead to side effects, especially in older adults. So what's recommended is vestibular rehab for more rapid and complete vestibular compensation rather than just medication prescription. But we still see a lot of older adults going to the ED and to their primary care and saying they're dizzy, being diagnosed with vertigo, sent home with meclizine, and that's it. So our goal is to increase the amount of frequency that people get referred to a physical therapist to address this, and so they can get vestibular rehab and fix the root cause of the problem. So what do physical therapists do for people with BPPV? Sounds kind of like voodoo, so what are we doing? We're performing a vestibular assessment where we're looking at the eyes, the motor movements of the eyes, and the balance, including all those listed tests there. We're identifying signs if they have central signs or signs related to a brain issue, we're identifying that. We're layering exam findings to support the medical team in determining diagnosis. This is kind of based in an ED setting. So practicing alongside a physician and aiding in a timely resolution. Let's get them better quickly rather than making them wait months to get treatment for this. So what else do? We provide education throughout the exam process so they understand what's going on, develop a rapport to reduce anxiety and intensity of symptoms. So a lot of times I'm meeting someone for the first time when they're really dizzy. They have an emesis bag in their hand and I'm saying, let me hold your head. I'm going to make you really dizzy. Okay, do you trust me? And they're like, no. So I have to educate them and tell them why we're doing what we're doing and what's going on, we think, and really kind of educate and get them to trust me quickly so I can help them. We're addressing any mobility issues and then making recommendations if we're in the hospital for where the patient goes and aid in smooth transition to the next level of care. And sometimes, vestibular is kind of a specialty area. So sometimes aiding in a smooth transition to the next level of care is like me calling the next physical therapist that the patient is going to be seeing, whether they're in rehab or home health or sending paperwork. I did this today with a patient. I sent paperwork for, what maneuver I did so the next therapist that saw them would know, because we can't always rely on the medical chart to make it to the next place that they go if it's outside of the system. So try to advocate in that way as well. Specifically, what is vestibular rehab? So we're doing targeted exercises to help with dizziness, the stability of gaze, and balance. So what might those interventions look like? We might do repositioning treatments, habituation, exercises, gaze stabilization, and balance training. And I have some videos of these things later on. Why is vestibular rehab important? It's costly. We've talked about this. These people undergo unnecessary testing a lot of times, MRI, CT, looking at their heart. They get medications they don't need, and their daily life and work is interrupted. So here are the components of a vestibular examination. We take their subjective history. This is a big part of what we do and kind of how we gather info. We have to look at their vitals just to make sure there's nothing else going on top of if there's a vestibular disorder. We look at how their eyes are moving, and this helps us determine if it's coming from the brain or the inner ear. Looking at their balance, their walking, and then lastly, we do positional testing, which makes them really dizzy if they have BPPV. So we kind of hold that until the last hurrah. Now, the posterior canal, I showed you the picture of what the semicircular canals look like. One of them is called the posterior canal. And based on gravity and the positions that our head are in regularly, specifically like sleeping and laying on our side, the posterior canal is what's most likely to be involved. So dislodged inner ear particles abnormally influence the balance system, producing vertigo. And we diagnose it with the Dix-Hallpike test, which I'm going to show you a video of. And most often, canal epiphysis, meaning that the crystals are free floating in that semicircular canal. Here is a picture of the Dix-Hallpike maneuver. So we turn the head 45 degrees to the side that we're testing, towards the ear that we're testing, and we lay the person back over the edge of the table. I'm hoping this video is going to play in the screen. Can you all see the video playing?
We can see the video, but I'm not hearing the audio.
There actually isn't audio. I just narrated this at the bottom.
Oh, okay.
Yeah. So you can see this patient, this person on a hospital bed upside down with the end taken off. We start them in a long sitting position, turn their head towards the side we're testing. So we're testing the left side, 45 degrees, and then 30 degrees of extension. And we hold that for 30 seconds. If we see upbeating torsional nystagmus, which you're going to see a video of, towards the ear being tested, like towards the left side in that case, that's a positive test. Usually happens within 30 seconds of when you lay them down, and it might last 30 seconds to a minute. So here is an example of a positive test. You're probably not going to be able to hear it in this, but that's
This
okay.
Dix-Hallpike test
Oh, you
is
can't.
testing the
Can you hear
left
it?
ear, which is the downward ear. It is strongly positive, which
Yeah,
is
we can hear.
Yes, we
diagnostic
can
for
hear.
posterior canal
Okay.
BPPV. When she's placed in the Dix-Hallpike position, nothing happens for the first 3 seconds. And then,
I'm dizzy.
you can see it there,
I'm very dizzy.
she becomes very vertiginous and has vertical upward nystagmus with a rotatory component towards the downward ear, which is the left ear. It lasts around 15 seconds. Is it sort of gone away now?
Yeah.
In slow motion, you can see the upward movement of her pupil, as well as the rotation of her eye, where the upper poles are beating towards the left ear, the downward ear. This is, again, a classically positive Dix-Hallpike test and diagnostic for posterior canal BPPV. This video demonstrates another characteristic.
Pause that because that's the most important part of the video. Okay. Any questions about what you saw? I think the slowing it down makes it easier to see, but a lot of times I am peeling the patients want to close their eyes when they're that dizzy. So I'm like, they're laying off the edge of the bed and I'm peeling their eyeball open because like it mentioned in that, we want to look at the upper pole of the eye. So like at the top to figure out which direction it's actually going because it happens really quickly. And it doesn't last long. So sometimes it's hard to see. There are special video goggles that help a lot with diagnosing this. Unfortunately, not everyone has them. I know Bellarmine has them, and then there's one specialty clinic in the area that has them. But a lot of places don't have access because they cost thousands of dollars, and then you have to have the technology available to see it. So like in the emergency department, if I had them, they would be hard to use on the computer systems that we have. So it makes it challenging. So this is the treatment for what you just saw, the crystals being out of place. Called the modified Epley or the cannulus repositioning treatment. So we actually start in the same position that we tested in. So we're going to treat the left ear in this video, the left posterior canal. We're going to keep the extension, the head tipped backwards, and we're going to turn to the other side, 45 degrees. That extension is why we have to hang their head off of the bed. Now we have them roll, tuck their chin and roll and look down at the floor. Down at my shoe is what I usually say. Turn their head a little bit more. They hold each of these positions for 30 seconds, for about a minute. So 30 seconds after their symptoms subside. And then they sit up and they look down at their elbow. So we retest after we do this once. We can do this treatment up to 3 times in one day. There is like a 90, it's in the 90th percentile that 3 treatments will address it. So 90, if they really have this, 90% of the time, 92 about, if we do it 3 times, it's going to resolve. So the the success rate doesn't really increase in one treatment session if you do it more than 3 times, but not every patient. You can imagine a lot of older adults have mobility issues, back pain. They're going to have a hard time tolerating those positions. So we can't always do 3 times in one session. We can't always retest. If they're really nauseous or they're vomiting, sometimes we can't do it. So it's just dependent upon how they're tolerating it and their mobility issues. And there are other adaptations to that maneuver that can be done for older adults. Specifically, if they don't have 30 degrees of extension or 45 degrees of rotation, there are other ways to address that. One way we can use a tilt table. The other way we can just roll the whole body rather than just the head. So we can still help people who don't have neck mobility. It's just harder. So the otoconia are the tiny crystals in the inner ear that I've been talking about. And here are some pictures of, I think these are rats, I want to say. They were from a study. So these are what they should look like. These are healthy otoconia. And these pictures here are fragmented otoconia from people who are more at risk of BPPV because they likely have a vitamin D deficiency. These other issues listed here on the left can also predispose someone to BPPV. So female gender, osteoporosis, migraine, head trauma, if they have high cholesterol. But there's no associations with smoking, drinking, or low physical activity. So if the otoconia are fragmented like this, they're more likely to fall out of place and the person is more likely to get this. So we can, something else I want to mention. These otoconia are the width of a spider web strand. So they're teeny, teeny, tiny. The whole inner ear fits on a dime. So we're talking a very small scale, but they can do some major, they can really cause some issues, even being so small. So preventing BPPV with vitamin D. There's a lot of stuff listed here, but the main idea is that vitamin D supplementation with frequent BPPV recurrence. Had a patient today who was in the hospital a month ago with BPPV. And she's back with a different canal being involved. But she's an older adult and she has other mobility issues. So when she gets BPPV, she's at high risk of falling. So she ends up in the hospital. So we are suggested to do vitamin D supplementation with frequent BPPV recurrence, but especially when the vitamin D levels are low. So if serum vitamin D is less than 20, then supplementation is recommended. But it's very important to always speak with the primary care physician about this before beginning treatment. This is the dosage, so 400 IU vitamin D and 500 milligrams calcium carbonate 2 times a day for 1 year. That's what the study used, and that's what was effective. So vitamin D can be used successfully as a supplement with frequent BPPV occurrence, but especially when vitamin D levels are low. Okay, so I listed what physical therapy encompasses for dizzy patients, and we're getting into what those things are. So habituation exercise helps decrease symptoms and allow patients to perform functional activities without motion-provoked dizziness. So some people with vestibular disorders will be dizzy when they get a lot of information to their visual system. So they turn their head, they get a lot of visual input, or just when they move in general. So habituation is designed to reduce the response of a noxious stimuli, but gradual exposure to provocative movements over time. So we do the things that make them moderately dizzy or mildly dizzy repeatedly until the brain recognizes like, oh, this isn't a danger. I'm not sending an error signal anymore. And over time, the patient becomes less dizzy. So time's allowed for recovery and to learn that movement is not a threat. And it helps desensitize the patient. You got something in the Q&A, so I was just looking at that. Okay, so the question is about precautions after having treatment for BPPV. Do they still give precautions after this? So this Dana was put in a neck collar, had to sleep sitting up. So there is actually, the research has shown that this is not necessary. The risk of the BPPV recurring is low after immediately is low. Now, if we're talking about people who are getting this constantly, repeatedly, like we're fixing it and then they're getting it again, those people, we might recommend that they have post-procedure precautions. But just for the first time somebody's had BPPV, trauma related, like in your incident, no, we would not really tell them that they have to avoid anything. But the biggest risk is laying on the ear, like sleeping with that ear down. So if you would tell your patients anything, you would say, just don't sleep on that side tonight. But no neck collar, no sleeping sitting up anymore, luckily. Good question. Okay, so habituation exercise. So these are examples of optokinetic stimulation. So this is stimulation of the visual system through videos. This is just kind of like one subset of habituation. And this might, I'm not really dizzy, but this provokes me. So this might be prescribed for X amount of minutes, however many times per day or per week, to help desensitize someone to a busy store environment if that is something that's provoking them. This might make them mildly or moderately dizzy, but if they got to a point where they're severely dizzy or have a bad headache or they are nauseous, then they would be instructed to stop watching at that point. So we just watch to a point of tolerance, and then we build up that tolerance. And the idea is that it translates to real life. So you get the idea there. And then this is another example of like a provoking pattern. So this would be a home exercise program that we would give somebody. Okay. So other examples of habituation exercise. So balance exercise that cause dizziness, walking activities with head turns, activities with balls or balloons where we're incorporating unpredictable head movements. So we're having them, follow with their eyes, the ball or the balloon. Outdoor walking activities, looking around and on uneven surfaces. And with young active patients, this might get pretty progressed, like jumping or bounding or diagonal head movements or moving in multiple planes, like twisting, rotating, and combined with cognitive activities. So things that make them, that challenge their brain as well. So we start, like I said, with activities that cause mild dizziness and then progress once they're no longer dizzy to more difficult activities until the goals are met. Okay, so gaze stabilization is the ability of the eyes to focus on one stable point when the head is moving in space. So we have a reflex between our eyes and our ears, the VOR, that keeps the visual world pretty stationary as we walk. We don't realize, we're kind of bouncing and moving as we're walking because our eyes keep that stable for us due to this VOR, the vestibular ocular reflex. But the dysfunction of the VOR can cause this oscillopsia or bouncing of movement. bouncing of the visual environment while we're moving. So this is what it might look like. So we can see how this would make us dizzy or be really disruptive to life. So this was made by someone who had experienced this. Okay. And so here are some examples of gaze stabilization exercises. This is the most simple one, and then ways to progress.
This is VOR times 1. The target is stable, but the patient's head is set in motion. Over time, it's good to increase the frequency of the head movement. And you can perform these in a variety of planes, horizontal, vertical, and then in a diagonal plane. And the patient is trying to maintain gaze stability during the exercise.
So they're looking at either a dot or a word, and they're trying to keep it in focus as they move their head as fast as they can while keeping their eyes stable. And they're working up to a point of moderate dizziness, not to severe dizziness. So easiest is seated with your feet on the ground, standing with your feet apart, standing with your feet together while you're doing those same head movements, standing one foot in front of the other, or walking. So those are only progress to the next stage as the stage before gets pretty easy. Okay, and then we've got balance exercises. So the purpose is to develop appropriate balance strategies when performing daily activities, even when the information from the balance systems, like being able to feel the floor, or being able, like the vision component of balance. So we have the inner ear, the vision component of balance, and then the sensation of the feet. If those are altered in any way, we can still improve balance by strengthening the other systems. But the exercise needs to be difficult enough to evoke a change, but not so difficult that the patient is going to fall. They need to feel off balance, but we maintain safety as well. And you can see the safe setup in this video. The exercise program should also include functional components that apply to the patient's individual goals. So we individualize these exercises. This doesn't look like this one's going to work in the screen. It's a bummer. Okay, well, this video demonstrates, I wonder if I can go from the current, no, that doesn't work. Can you see the same slide that says balance exercise?
I've just got a blank screen right now, a blank
Right.
white screen.
Yep.
Okay. All right, I don't think I'm going to be able to get that one to work. But she's standing on the balance beam. The dog comes across in front of her, and she throws a ball across her body for the dog to fetch, and she follows the ball with her eyes. She starts by looking in the mirror and then follows the ball with her eyes. So she's moving in a rotational plane. She's got a lot of visual information by looking at the mirror and across the room, and she's challenging her balance by standing on an unstable surface. So lots of things that are challenging her balance, but she has a gait belt on and a physical therapist assisting her. So we're kind of keeping her safe in that way. So when we're designing a balance exercise, I should have asked. Is it still a white screen, or can you see the slides again?
We can see, I can see the screen. It's designing a balance exercise.
Thank you. Thank you. Okay, so the somatosensory system, or the feeling on the bottom of the feet, we can alter that when we're designing a balance exercise program or an exercise. So the wider the base of support, the easier it is. The more stable the surface, the easier it is. And then visually, we can change by having the eyes open. That would be the easiest. Putting the patient in the dark would be harder. A busy or distracting environment would be difficult, or eyes closed would be more difficult. As far as vestibular information, we can have the patient move their head, body and head movement together, or body and head movement separately. So lots of things we can alter to change different balance exercises to suit the person. We also love to have a walking program. So it's important to focus on functional tasks, reduce non-use. We don't want dizzy patients to not move. We have to figure out safe ways that they can move outside of therapy. So we're not promoting a non-use pattern. We want to promote recovery. So we want them to turn their head, look around, have dynamic challenges while maintaining safety. It helps to walk with a partner. This can empower them and motivate them and maintain some supervision while recovering from their dizziness. And if they need to use an assistive device outside of therapy, that's fine, like a cane or a walker. Just very important to get out and move. So if we're talking about dizziness and falls, we definitely need to talk about what happens when you hit your head. Older adults can experience concussions, and talking about and asking about concussion symptoms might be the best indicator in concussion in older persons, because imaging is not going to find a concussion. So consider asking concussion questions to older adults who have had any fall-related fracture. They might not remember that they hit their head. And that can be part of the concussion if they have, loss of memory of that incident. So if these are some symptoms of a concussion. So it's important to screen your patients to see if they have headache, cognitive changes, slowness in their thinking, any kind of confusion or mood changes, neck pain, changes in their balance, their energy, changes in their sleep. If their eyes are getting really tired, blurred vision or eye strain, or increased sensitivity to sounds, lights, and motion. So how do we treat older adults with concussion? Well, we treat them like we treat younger adults, but potentially more conservatively. And we're looking at, are they at risk for falls? Do they need more support from a caregiver? We want to get them moving as quickly as we can to reduce that non-use. We want to do exercises to improve balance, decrease dizziness, and address any pain that they're having. Want to work with their doctors to get their headaches and sleep under control, as this improves their outcome. They may need medications. And then vestibular disorders can also, just without the concussion, vestibular disorders can influence cognition in older adults. So what might happen is the brain prioritizes the attention resources to maintain balance, because it's gotten to be more of a struggle, at the expense of cognitive tasks. So the brain abandons the cognitive task in favor of the motor task to keep the patient. It's like a survival instinct. So they might have some difficulty multitasking or fogginess, memory loss, or confusion. So vestibular rehab targeted to improve their balance, decrease their dizziness, should help reduce the need for those compensatory mechanisms by the brain. Now, when we looked at the list of all the causes of dizziness, when should we suspect cardiac or medical source of dizziness? If the dizziness is paired with syncope and collapse, we're very suspicious. The patient needs to have their heart looked at. Now, even though physical therapy is not the primary treatment for these patients, our involvement can play an important role in the patient receiving a diagnosis, especially if the dysfunction in the blood pressure or the heart rate is happening only when the patient is moving. So this is a big reason why we assess blood pressure, heart rate, and symptoms in sitting, standing, and after activity to rule out orthostatic hypotension, so a blood pressure drop as gravity, as you stand, the blood pressure drops progressively. Exertional hypotension is a drop in blood pressure from walking. It doesn't necessarily happen just when you stand up. And then some people have POTS or postural orthostatic tachycardia syndrome, where their heart rate gets really high just when they stand and move. And that might cause them a lot of dizziness. And some other causes of dizziness are listed on the right. Okay. So does any, okay, I see another question here. Can you still do gaze stabilization with Parkinson's patients who have severe tremors or shaking of their head? We can, and people who have head tremor do have increased incidence of dizziness. So yes, we can work on that. Now there's more rigidity in the cervical spine with Parkinson's, which makes some of the testing and treatment of dizziness difficult, but there's always adaptations that we can do for those patients. They might need more assistance doing the exercises, but we can certainly adapt the exercises to work for them. Good question, Dana. Does anybody else have questions? Feel free to unmute yourself before we go into this last little patient case.
Hi, Shelby. This is Yesenia. I did have a question on the habituation exercises you were showing.
Yes.
Just wondering what is, I don't know if you can answer this. What part of the brain is being affected when you do a habituation exercises over a period of time? Because I'm curious if it's like physical changes with the crystals in the vestibular system, or is it something in the visual cortex? Is it something in the cerebellum? I just curious to know, over time, repeating the same exercises, is it, I think what I'm not sure how I'm asking this or if it's making sense, will those changes stick? Or is this like a lifetime of doing habituation exercises?
So typically, if it's a central cause of dizziness, it's either the cerebellum or the cerebellar pathways that are involved. So the changes would be to the cerebellum. Now, a lot of people, once you make the progress with the habituation exercises, you tend to keep that progress, but some people have to continue to do some basic exercises so they don't lose that progress or go backwards, people that are very motion sensitive. But a lot of my patients that I've done habituation exercises with, they can get to like 90% better with physical therapy. And then the last 10% kind of comes from life, from just like re-establishing all the normal activities that you do that challenge you. And then kind of life helps you get that last 10%. So I haven't seen a big regression when people stop physical therapy. There might be that last 10% of dizziness that doesn't ever 100% go away, but they do get progress that they can keep without constantly doing habituation exercises.
Thank you.
Anybody else? Okay. So this case is someone that was an older adult that just illustrates how complex dizzy case can be and kind of how many things we're managing here. So I'll go over it in the last few minutes. So a 72-year-old female was finishing up her last day at a skilled nursing facility when she was transferring from a stationary bike to a transport chair that was kind of top heavy, I guess, and the wheelchair tipped backwards and she hit the back of her head the day before she was being discharged home. She had met all of her goals, just really sad, but she ended up with a subdural hematoma, subarachnoid hemorrhages, complained of dizziness and nausea with all mobility. At baseline, she was independent, lived alone, and there was some suspicion by the medical team that she had BPPV based on her symptoms, on top of the subdural hematoma and the subarachnoid hemorrhages that she had. So she actually ended up having some focal seizures throughout her stay. When she was started on seizure medication and cleared by neuro, the patient was assessed for BPPV. So her blood pressure had to be under 150. So we monitor blood pressure anyway, but we definitely monitored it with her. We did the Dix-Hallpike test that I demonstrated earlier, and she actually had a positive test on both sides, which is rare, but more common in people with head trauma. Her roll test for the horizontal canal was negative. She did have orthostatic hypotension, so she had some layered issues going on. So I informed the medical team about that. So here are the pertinent findings. She was treated for the hypotension because I think it was contributing to her dizziness with walking. So we retested, I treated her with, I picked a side to treat. Which side did I say I treated her? I picked a side to treat, and then I came back and retested the next day. We only did one repetition of the cannula 3 positioning treatment because of her mobility issues and her symptoms. So we came back the next day. She was still positive on the right. The right side is what I treated the first day. But with the roll test, she was positive now for horizontal nystagmus on the left. So we converted her. She had probably a lot of debris in her semicircular canals, and moving her around and treating her led to her converting to the horizontal canal, which her symptoms were more intense. So the left side converted to horizontal. So now I had to treat her for horizontal canal BPPV, canal conversion. So very complex case. So I treated that side that day because it was the most involved, and she was leaving that day and going to a skilled nursing facility again, the same one that she fell at. So I contacted that rehab facility and talked to the physical therapist that was going to be treating her to promote a smooth transition of care, because I anticipated I wasn't going to be able to fix it before she left. And this was a successful interaction. I provided handouts to her on BPPV, concussion symptoms, and talked to her a lot verbally about what I was seeing. She was a great self-advocate and received the education well and tolerated treatment well. Her recovery may be protracted because of all of the issues, but achievable with a targeted approach. And like I said, up to the mid 90 percentile, these cases can be resolved with up to 5 repetitions of this treatment. So very effective and useful for these older adults. So thank you all for your time and your attention, and thank you for having me. That is it.